Welcome. I'm very pleased to be here with all of you for this session of what changes on Monday morning post San Antonio 2021 with a focus on ER-positive disease. I'm Ann Partridge and I'm a medical oncologist from the Dana-Farber Cancer Institute. And I'd like to have each of our illustrious panel members introduce themselves. So I'm going to go around the Zoom square and I'll call on each of them. And we've all agreed up front that we're going to go by first names tonight and not give all the titles that everybody has. Dr. Mamounas, do you want to start?
Yes, Terry Mamounas, a breast surgical oncologist, and I work at Orlando Health Cancer Institute and also work with energy oncology.
Thanks, Terry. Dr. Goetz?
Hi there, I'm Matthew Goetz. I am a breast medical oncologist, and I work located in the Mayo Clinic in Rochester, Minnesota.
Thank you, Matt. Dr. Warren?
Good evening, everybody. I'm Laura Warren. I'm a breast radiation oncologist at Dana-Farber in Boston.
Thanks, Laura. And last but certainly not least, Ms. Heditsian or Diane.
Hi, I'm Diane Heditsian, and I'm a patient research and policy advocate for breast cancer. I work with UCSF and Stanford and a number of other institutions around the country. Well, happy to be here.
Thanks, Diane. Thanks for joining us all. All right, so we'll get started because there were a lot of exciting abstracts presented at San Antonio and lots of themes in ER positive. One of the biggest themes in ER positive was updated results. So lots of updates from really important and impactful trials over the last several years. So the first one that I want to focus on is the update of the PALACE trial that was presented by Michael Ganant on behalf of the ABCSG and the AFT. And as many of you know, PALACE was the randomized trial of the addition of palbociclib to endocrine therapy for patients with early stage hormone sensitive breast cancer. Matt, do you want to get started and maybe give us the skinny on what the PALACE update showed us?
Yeah, so as Dan, as you said, this was a really very important large trial, which is looking to bring the CDK4/6 inhibitor palbociclib into the adjuvant setting. Of course, we had the initial results that were published earlier in 2021, and so this was really the final results presented by Dr. Michael Ganant. And unfortunately, as we know, this was a negative trial. What we didn't see with this particular trial was, obviously we didn't see a benefit in terms of an improvement in invasive disease-free survival. But I also, importantly, we didn't see an obvious, subset of patients that were obviously seeming to benefit from palbociclib either. And I think really what this does, of course, is it brings up a major question, and why, and that is, right now we have 3 CDK4/6 inhibitors, and we have 2 that have been reported in the adjuvant setting. One of those, obviously, showing no improvement in invasive disease-free survival. That's the palbociclib, and the other, the abemaciclib. So there's a lot of questions about why, and I think people are looking into that. But for right now, I think we have a final answer about the role of palbociclib in the adjuvant space.
Thank you, Matt. And does anybody want to comment on the fact that they looked at the subsets a little more granularly in this group and tried to compare? I can comment on it. They tried to compare the Monarch E subset and the highest risk group of patients in PALACE, and it really was pretty strikingly negative, as in palbo did not add benefit. So it's not about a difference in the population as far as we can tell. Maybe it's a difference in the way the drugs are given or the drugs themselves. And there was some speculation about the fact that, as we all know, when you give palbo, you give that 7-day break. And when you give abemaciclib, the other CDK4/6 inhibitor that has had the positive results, you give it straight through. I don't know if anybody wants to comment on that.
I guess I could comment on that because, if we think a little bit about the these drugs, obviously The other drug, which has not reported out yet in the adjuvant space, is ribociclib. And we won't have data for a while from the Natalie trial. But if we at least look in the metastatic setting, what we are seeing, of course, is a clear survival and consistent survival advantage and signal for ribociclib, which is also a discontinuous regimen. It's 21 days on and 7 days off. So while I agree with you that certainly the schedule could play into this a bit, it doesn't quite explain even now the discrepancies that we're seeing in survival in the metastatic setting. Certainly I think another thing that people have thought a little bit about, and that is the fact that these drugs might be hitting additional targets. There may be effects on some of the other CDKs, including the CDKs that are associated with a more aggressive disease such as cyclin E or CDK2. Clearly, these are a drug like abemaciclib is not a potent inhibitor, but what we don't know for sure, for example, is if you're giving the drug over time, does the drug actually build up in the tumor, in tumor cells over time, that perhaps we're getting some effect in terms of some of these other CDKs. So I think we're still learning quite a bit about these drugs, and I think hopefully over the next few months to years, we'll be able to learn about why did one drug work and why did the other one not work.
Yeah, Matt, you bring up a really good point. I think two other things I wanted to bring up is it's great that there was no clear new safety signal, though, at least. So, we have to study these things. All research is super important. These large trials, even when they're negative, we learn from them. And this study, there will be, we will learn a lot from all the biospecimens and all the data collected. And there was even a PRO component and an adherence component that were reported out at San Antonio as well. But I think, Diane, do you want to comment on, from a patient perspective? It's a negative trial. Patients are aware of that. Unfortunately, no new toxicities, but thoughts about this when these kinds of things come out. I assume they hit the presses. You want to share your thoughts on that?
Sure. Obviously, reporting out on a negative trial, we advocates really appreciate because often they're not reported out on. So we want to know the whole story. And you mentioned PROs. I think we're using those much more now, and that's a wonderful thing. And I think people are appreciative that the patient voice is being heard at places like San Antonio now, and the FDA with their requirements, and so it's a very important step for us. But choice is always important, so I say bring them on. Let's keep testing.
Thank you, Diane. I appreciate that. And just one final point that I want to make is, does this change any of your thoughts about which agent one chooses in the metastatic setting? We know that these are, three very active agents, the CDK4/6 inhibitors, ribociclib, as you mentioned, abemaciclib, as well as palbociclib, as was tested in the PALACE trial. All have good data in the metastatic setting for benefit, whether it's PFS or OS or both. Thoughts on that? Matt, do you want to start?
Sure. I think this is a really important question because as we look across these different drugs and we have a patient in front of us, I think it becomes very clear if we have definitive data that one drug prolongs survival and one does not, then it becomes easy. I think we're still waiting. And so I would not presume to say that we have that data from palbociclib. I hope we have that data very soon from the Paloma 2 trial. But once we have that data, then I think it becomes clear. If I'm seeing a patient in front of us, this is a drug, let's say in this case ribociclib, and we see a consistent survival signal. And if we have another drug where we don't see that, then it becomes clear. I think we're not quite there yet, though, and we need a little more data.
Yeah, I know, Terry, I don't know if you want to add anything to that. I realize you're a surgeon and not usually treating metastatic disease, but you know all things breast cancer.
No, I mean, but I'll make the comment also from another early stage trial, the Penelope trial with palbociclib, that also was negative. It was a 1 year duration. It was shorter, but it was a post-neoadjuvant setting for patients that had significant residual risk. And that also was negative. So for whatever that's worth, I think we have 2 trials at least with palbociclib that have been negative so far.
Yeah, I think what's interesting about the Penelope trial was that it looked like it was going to be positive, and then when they followed them out to 3 or 4 years beyond, it actually went negative. And so I think it'll be really interesting to see what happens with Monarchy. I hope it stays positive, but we haven't seen that yet. And I hope, we want, of course, something to be positive here. It's just that it's just a little head scratching why one's working one way and one's not working the other.
Well, I think what we need, and the reason the FDA approved abemaciclib as a drug in the adjuvant setting was because what they saw was that patients were going off the study. And I think at the most recent manuscript that we just published, about nearly 80% of the patients were off the drug. But yet, from the time we went from less than 50% to now the majority of patients being off the drug, the benefit was maintained. So that's the critical thing, Anne, that you're saying is that we're giving these drugs for a short period of time, and if we're benefiting only in that 2-year period, it's a useless drug. So you really have to see evidence that that benefit is maintained, and that, of course, was in part the reason the FDA approved abemaciclib. But we certainly need longer-term data. To really see if, to use the term carryover, that's a term that's used very loosely, but, the bottom line is you stop the drug and you have to see that the benefit is maintained.
Right, we want those curves to stay separated.
Exactly.
Yep. All right, thank you. Let's shift gears a little bit. We're going to stay in early stage, of course, hormone receptor positive breast cancer. And some of the biggest data presented was, as usual, from the Oxford group, the Early Breast Cancer Trialist Collaborative Group, where they presented a new meta-analysis looking at our youngest patients, the premenopausal patients, and the value of aromatase inhibition versus tamoxifen in women who have undergone ovarian suppression. This was a study of over 7,000 women from 4 randomized trials that suggested that the aromatase inhibitor is the winner. I think we should discuss that in the context of the text and soft update that was presented, which I'll get into more specifics about in a few minutes. But let's first start with this big analysis, which had text and soft in it, regarding AI versus tamoxifen. I don't know who wants to start with that. Do you want to start again, Matt?
Sure. So, I think this was a very important sort of a first step, looking at bringing in all the trials, HOVO, bringing in ABCSG12, obviously soft and text, and looking at patient-level meta-analysis to ask the question of, what is the role of ovarian function suppression, and of course, what's the role of aromatase inhibitors? And I think what we can see, of course, is that without a doubt, ovarian function suppression right now is a clear winner, and it should be considered a standard of care in this scenario. The aromatase inhibitors give you a little bit additional benefit. There's no doubt about it. We have yet to see from this meta-analysis an improvement in overall survival with regard to the addition of the aromatase inhibitors, but I think all of us right now are very reassured that we did not see with this meta-analysis there was no concerning signals that I could see from these data, for example, with regard to early death. What we're really going to need, of course, we always say this, but we're going to need longer term follow-up. But I would say my number one take-home point is that ovarian function suppression is here to stay for these patients. And number two, for those higher risk patients, we have clear data that aromatase inhibitor adds. And then what we'll need long-term, of course, is to answer the question from this meta-analysis, does the addition of an aromatase inhibitor improve overall survival?
Yeah, I think, there was about a 3% advantage from the AI over tamoxifen for the whole meta-analysis. And as you astutely noted, no overall survival benefit out, over 10 years. So when, and so in higher risk people, the benefits were greater as the nodes got further, got to a greater number. But when you're dealing with someone with moderate risk and they're struggling with an aromatase inhibitor, definitely not a no-brainer, or it's a no-brainer actually to get them potentially onto tamoxifen and not keep them on the aromatase inhibitor. Diane, do you want to comment on that? Because, you know, not presented as part of the overview as you can expect, and not updated in text and soft, although we'll talk about that one more specifically in a few minutes. You know, adherence and tolerability is a huge issue for hormonal therapy, particularly for our youngest patients.
Right. I've been on hormonal therapy, endocrine therapy twice now in my life with my 4 breast cancers. And 19 years ago, it was horrible. I was on an aromatase inhibitor because I couldn't take tamoxifen because of blood clots. I'm factor V Leiden. And, but I have to say that as you go out farther from menopause, the side effects become less bad. And in both cases, I still have 4 months left. I'm crossing off the calendar by day till those are over for the second time. But I stayed on it both times because I think women do understand that the impact that these have on their future. So what I would ask physicians to do is to set expectations prior to the prescription and to work with them on workarounds. I mean, there are workarounds out there for these side effects. And Pilates has saved my life, right? Because it just helps with my side effects. But I can tell you the first time was it ruined my life. I had a business. I had to hand that over to someone else for the duration to run. I mean, it just devastating. So the other thing I just wanted to say is right before I got on this call, I was taking a call from a new patient, 31 years old, just diagnosed with ER-positive breast cancer, and her fiance. And one of the first 2 questions they asked me was about fertility. So when we talk about, suppression, it just makes me just tense up. And I think every oncologist needs to send their young patients to a fertility specialist. Breast cancer is usually not an emergency, and they need to learn all their options because this is their life. I mean, some women have wanted children all their lives. Okay, so this is important.
Thank you. That's a really important message, Diane. We all agree, I know. And I think, the good news is the hormonal therapies themselves don't cause infertility in any way. It's the time it takes to get them. And of course, many young women do need chemotherapy, and that can very much cause infertility. But you make a really important point, and we appreciate that. In the soft trial, just to bring up that next abstract we wanted to talk about, they gave an update. And then now we're at 12 and 13 years for text and soft respectively. And the nice thing is that the results are holding strong, and they're becoming even clearer that clear benefit, as you said, Matt, from ovarian suppression in premenopausal women who have enough risk to warrant it. I think overall, tamoxifen was the winner in text and soft in the sense that for the vast majority of women who were the lower risk women, tamoxifen was good enough. So in premenopausal women who didn't need chemotherapy or were under 35, the overall recurrence or disease-free survival was over 95% in all groups at 12 and 13 years. So that's like win-win, right? You can't get much better than that in terms of, people not hearing from breast cancer again, although I'd like to get to 100%. So I think for the lower risk populations, tamoxifen can be the mainstay, and not everybody needs ovarian suppression. I'm happy to talk about that. But for the higher risk people, that's where you see the real delta. And that's where you're going to see it with the aromatase inhibitor, even compared to tamoxifen plus ovarian suppression. But just thinking about Diane's, not an unfamiliar story of intolerance, especially for some of our youngest patients. Tamoxifen alone is still okay if you can't tolerate the ovarian suppression. It's still better than not taking medication. I don't know if anybody else wants to comment on the text update, but there's a clear survival advantage too from the ovarian suppression and the AI in the highest risk patients, node positive, needs chemo, under 35 and high enough risk. I don't know if Matt or Terry want to add to that.
Yeah, I mean, it's reassuring that, with more follow-up, we still see a very good benefit and that it persists. So I think that's something that obviously is becoming pretty much the standard. And there was some other information in San Antonio that obviously the rate of ovarian function suppression is increasing compared to a few years ago. So I think it's here to stay, and we're going to try to find out the best way to use it. Right now, it appears with an AI is the best way to use it. If you can get
as tolerated. We need the supportive care clinics to grow, right? Make sure everybody knows about Pilates and acupuncture and the things that help people, right?
If I could just make one other comment, and that is, it still comes down to this, and that is that, there is the ideal, which is that patient you have in front of you who you say, listen, this really makes sense to be the most aggressive, which is, ovarian function suppression and an aromatase inhibitor. But then there's the reality about, what we see in our clinic and what patients can tolerate. And I think what our clinicians really need to know, that is that if a patient cannot tolerate, ovarian function suppression and AI, please don't forget the other options. One of my colleagues once said that tamoxifen has saved more women's lives than any other drug in the history of all oncology. So don't all of a sudden say, well, gee, I'm going to throw up my hands. My patient can't tolerate, ovarian function suppression and the AI. I'm going to give up. No, we have to work with our patients. I find some of my patients, we give them a holiday, and then we go back to it, and later, for whatever reason, they're able to tolerate it. So it's a constant dialogue. We need to have those discussions with our patients and realize that there are options if that most aggressive option doesn't work, and the patient should feel like they haven't failed. Gee, I haven't been able to tolerate the most aggressive regimen. That's okay. We'll work with you to get you onto something.
Right. Some is better than none. Matt, do you want to also comment on, there's a question from one of our viewers about duration. Now, there wasn't an update about the duration of therapy. There were some data from our group about extended endocrine therapy in our youngest patients, but the question specifically is it recommended to use AIs for 5 years or 10 years? They don't specify whether it's for a premenopausal or for a postmenopausal, but do you want to comment on that?
We've heard a little bit about this in the past. Again, the Early Breast Cancer Trials Collaborative Group has had several presentations, and I believe we're seeing a manuscript that's going to be coming out sometime, hopefully in the next year, that's focusing on the issue of duration and really an update on the issue of what we're seeing now in our clinic, which is the question of AI after AI. Who benefits? What subsets? What about age? What about if, for example, if you start with tamoxifen and then you move to an AI versus you start on an AI and then you go to 10 years. So we've seen bits and pieces of these data at some of the meetings. It wasn't presented at this meeting, as you said, Anne, but I do anticipate that we should be seeing an update with regard, at least from the Oxford overview, with regard to this question.
The latest data, as I recall, suggests that 7 years is kind of the sweet spot for our postmenopausal women based on the ABCSG study of 7 versus 10. And unless they were particularly high risk, 7's probably good enough. Although some women I still keep on for a while if they're very high risk. I think for premenopausal women, if they're still very young, Diane, like that 30-year-old you spoke about, and let's say they get their ovarian suppression and their AI for 5 years, we actually don't know what the most effective therapy is in the second 5 years. And if they're high enough risk to have warranted that to begin with, maybe chemotherapy, we certainly want to do something for them during that second 5 years. And there's no clear data to inform that available yet. We have data for 5 versus 10 years of tamoxifen, and that included premenopausal women, but we have no data right now available for the efficacy of anything in the second 5 years for women who've been treated with ovarian suppression and either an AI or tamoxifen right now. Someday we will, and we actually are proposing a trial to study this, to say, do you need more ovarian suppression in that second 5 years? Or would it be good enough to just switch those women to tamoxifen alone? So you're getting some coverage, but not necessarily all the risks of the ovarian suppression. Stay tuned on that. We don't have an answer though yet.
Yeah, I mean, it's interesting, because, we should have some data in patients that get oophorectomy where they have a permanent suppression for more than 5 years
Right.
versus 5 years. And some people may actually choose to do so after a while because they get tired of the SADs. But it's an interesting question. But I agree that, the 7 to 8 years of extended or total endocrine therapy appears to be optimal, at least for an AI, when AI is involved. Obviously, the meta-analysis showed that the benefit when you switch from tamoxifen to an AI is larger than when you take tamoxifen for 2-3 years AI and then an AI. And then it's even less when an AI for 5 years is followed by additional AI. For whatever reason, it appears that the switch from different drugs work better. But yeah, we're going to have an update on that duration. But indirectly, I think the data suggests maybe you don't need the 10, but you definitely need more than 5. So 7-8 years probably the sweet spot, depending on tolerability.
Yeah, for our moderate to higher risk people. Some people you can get away with 5.
Yeah, and of course, yeah, high risk.
Laura, we focus a lot. I know you're not giving these drugs, but you're part of the multidisciplinary decision making around, what's the best therapy, and you're seeing the great news, right? We're quoting 95% survival, disease-free survival for premenopausal women. Some of them getting tamoxifen alone. How does that impact on your local therapy decisions?
Thanks, Anne. That's a great question. I think the good news is, in the era of increasingly effective systemic therapy, our rates of local regional recurrence just continue to downtrend, which is fantastic. And so what that means is the absolute benefit of radiation therapy is also getting smaller. I think the relative benefits remain the same. So I guess for me, thinking about that, I think there's the rare patient who comes in to see us for discussion of adjuvant radiation who's really against adjuvant endocrine therapy. While I encourage them to try and go back to their medical oncologist and discuss it and at least, see how it goes before they change, truly say no. I think in that patient, that's a patient where it's a sort of no-brainer to try to escalate local therapy if they're truly declining adjuvant systemic therapy or adjuvant endocrine therapy. In other patients, I think I spend a lot of my day trying to kind of risk stratify patients. And so for when medical oncologists are escalating systemic therapy, I think that gives me pause and makes me think perhaps those are those patients who may need PMRT or may need a regionally nodal sort of directed field. But I think in general, for patients, particularly with limited nodal disease, we're going to get an effective systemic therapy. I think we're trying to walk back some of our PMRT, some of our regional nodal irradiation. So I think our field is evolving as patients are doing better and better. And I think that's what you're alluding to.
Well, that's great. That's great. And I'm sure, and Terry, I'm sure you have thoughts on that from the standpoint of, how many nodes do we need to get out? What can we do in the 1 to 3 positives? As long as people are going to take their endocrine therapy, who really need, for older women, who really needs, radiation if they're going to take their endocrine therapy and it's a small node negative tumor.
Yeah, no, I mean, I think it's a great topic and one that is kind of changing. I think obviously we've de-escalated, axillary surgery. We send lymph node biopsy, we take less and less nodes, decrease in lymphedema. And of course, with a center node, we also scrutinize patients more so now. So if you have 2 or 3 nodes removed and you scrutinize them, when you say you have 2 or 3 millimeter metastases, you're pretty certain about that. In the older days, when we used to take 15, 20 lymph nodes with an axillary dissection, and one cut was done in the nodes and they looked at both sides, and if there was no tumor, declared them negative. Then later on, we found out some of these patients were not positive with, more detailed assessment. So even just the mere application of the sentinel lymph node biopsy has actually allows us to be more accurate in staging patients and identifying patients with positive nodes where otherwise would have been non-negative. On the other side of this, though, these node-positive patients actually do better. And when you look at the data on post-mastectomy radiation and regional nodal radiation from the overview analysis, the numbers, the percentages of recurrence are much higher than we saw in some of the more recent trials, where we gave adjuvant chemotherapy and then did not give post-mastectomy radiation, namely, for example, in the B28 study and other studies, local regional recurrence rates are much less. And of course, then with genomic profiling, we can even subcategorize these patients even to a lower risk, making us able to perhaps tailor that therapy. And some of the studies are, as you know, currently ongoing, trying to not radiate necessarily everybody with 1 to 3 positive nodes after a sentinel lymph node biopsy or an axillary dissection. So there's a lot more.
It is tailored and personalized because we're getting smarter, and some people, bad cancers still occur, but not every cancer is necessarily going to need everything.
Right.
And that's really good for what Laura said about, backing off, de-escalating on the radiation, because it levels the playing field more too for the socioeconomic and racial disparities, because we find that radiation is particularly hard for people who are have to show up at work every day and who have children. And so, that works for everybody.
So Diane, that was the perfect segue because I think we should shift to the discussion. If you saw at the debate, for anybody who was watching San Antonio, there was a debate regarding the duration and fractionation of adjuvant radiation therapy. Laura, do you want to tell us a little bit about what the pro was and what the con was, and why I'm hooking that up with Diane and her comment?
Absolutely. I think just to sort of step back in time, I think I'm thrilled that I practice in an era where we have moved away from 6 to 7 weeks of radiation for the vast majority of our patients. So I think, looking back historically, regardless of what was being radiated, patients got quote unquote conventional fractionation, which is 2 gray a day. And then I tell my patients all the time, luckily some very smart and very brave patients in the UK, in particular in Canada, enrolled on trials where they did, I think, really elegant radiobiology studies that showed that we can actually deliver radiation more quickly and more dose per day and do it safely and do it well. And so I think the sort of predecessor to the debate, if you will, were the Canadian and the UK trials that were now presented in their sort of long-term form 10 years ago that said we can do hypofractionation. I'm not in the weeds about the debate, but really briefly, I think we're still trying to figure out, can we use our 4-week regimen in patients with, for example, breast reconstruction. And so we just completed a trial looking at that at Dana-Farber, a multi-institutional trial, and there's a national trial, RT-CHARM, looking at that as well. There's some Asian data that we can, and I think many institutions have already adopted that for post-mastectomy radiation. But the spirit of the debate is really, can we push that further? Can we really say 16 is too many for lots of reasons, and can we get away with 5? And so these 5 fraction regimens, specifically kind of the original study UK Fast and now UK Fast Forward, are trying to accomplish breast radiation in 5 days. And I think it was a spirited debate, and the bottom line is, I think my takeaway is many centers are already headed that direction. Certainly our group is doing it for older patients who the logistical burden is tremendous. We only have 5-year data. And so I think the hesitation to more universal adoption, in my opinion, is the long-term toxicities. These are patients, they're low-risk patients who are going to live a long time. And I think we conservative and certainly open to criticism or not, are just want to ensure that sort of longitudinally we're thinking about their long-term toxicities in addition to their cancer control. But I think it's coming, and for better or worse, COVID has pushed us that direction.
And Laura, it makes sense just based on Diane's comments. You could, if a person couldn't otherwise logistically make it to radiation, and their breast cancer is, risky enough and their setting is enough to warrant radiation, then of course, like, you said, a low risk older person where you're not as worried about the very long term. But I think we could even widen disparities if we applied this wholesale, particularly to groups that couldn't get in because they may be set up for something worse 20 years later if we're not careful. I'm not saying we shouldn't adopt it, but you could make new disparities by applying it in ways that ended up not being good for patients.
Couldn't agree more. And I think there are good data to show that distance from a radiation oncology center impacts people's surgical decision making. So if these are patients for whom lumpectomy and radiation would be recommended, but radiation is not feasible, that's a widening of a disparity right there in terms of psychosocial outcomes and other outcomes that result in mastectomy for patients who otherwise would be oncologically eligible for lumpectomy. So yeah, I completely agree, and I think food for thought, and will be an ongoing debate, I think, particularly in the US. I think around the world it's less of a debate.
Well, so can I just push you a tiny bit, and maybe Terry, you could weigh in on this as the other regional local person. This is called What Changes Monday Morning. It's past Monday since San Antonio ended, but what's changing based on, even though they didn't present new data, they showed us the data from Fast Forward and updated it. And are we heading in that direction for some, many, not all, obviously?
I think to be fair about my own practice, I think that was a fun debate, but my practice had already started to shift with COVID. So I think if the driver is the pandemic for me, we see patients from a distance too in Boston, from Maine, from down the Cape. I think those are the patients too. But I would say my practice had already started changing. So I don't think it's changing Monday morning, but I think it was an opportunity for people to see those data presented in a clear way. And I imagine some radiation oncologists will change their practice as a result, at least for a subset of patients.
Yeah, and I think if you heard the debate, and Julia White presented the con argument, but essentially her concern was maybe the long-term data are not necessarily all there yet. But I think that it became evident that if somebody showed up on Monday morning in her office, or I don't want to paraphrase what she said essentially, but it's like, and somebody wanted 5 days, I think she'll feel comfortable giving it for 5 days. So I think the data speak for themselves. I think it's something that can be done now. But of course, practice change is difficult and sometimes takes a little longer. The other thing I want to mention very briefly is that we also have data with partial breast radiation that you can also complete in about 5 days. It's twice a day. And, with the NSABP trial and several other trials, there was very little to almost no difference between partial breast and whole breast in local recurrence. The absolute difference was like 0.7%. So it's another good option for patients, particularly if you want to kind of say move away from the heart and the patient has some concerns with whole breast radiation. It's another very good option, and you can complete it in same like 5 days. So
pushing the envelope a little further, were there any new updates on intraoperative? Right, then you don't have to come at all.
Right. So maybe I'll let Lauren also comment on that, but I can give you my take. What we know so far, obviously it's very convenient, you can do it. However, the rates of local recurrence with intraoperative radiation is a little higher than, at least in my take on the data. So we don't necessarily offer it to patients. I mean, not to say that some patient may not be a good candidate with a very low risk, and intraoperative is better than nothing, for example. So I'll let Lauren sort of give more expert opinion on that one.
No, I like that. I think the reality is probably a fair number of the patients getting intraoperative radiation don't need radiation at all. Yeah. And so I think that while I agree that actually for some patients something is better than nothing, I think for some patients nothing is the best. And so my take on intraop is yes. I think in some of the series that we've seen, unselected patients, they have higher risk of recurrence, and that's unfortunate, because I think part of it is patients get very attached to what you tell them up front, of course, and if it makes, that's what they're expecting you to sort of walk them through the care path. And I think for some of those studies where they're giving intraop and then seeing the final pathology and then advocating that patients are coming back for whole breast, that's a big pivot in terms of your life responsibilities or your expectations of care. So I think that's a challenging conversation. Not to get in the radiation weeds, although of course I picked the field for a reason, but I think there are technical aspects to all of this that also make some of these techniques more or less appealing. So intraoperative radiation, I think, just requires a technical expertise of both your surgical and radiation team, in addition to the technologies that in some places might be better and in some places is not. So I think external beam, partial breast, external beam, whole breast is just widely available in a way that the more we can generate robust data there, the more patients will have access to these evolving regimens.
Thank you.
Right. Let's stay on the local therapy for another couple minutes. And we did see some data on surgery. We had the Synadar trial. Terry, do you want to tell us about that study and the questions it was asking about dissection or not in not so high risk node positive disease?
Yeah, so the Synadar trial essentially was a very similar trial to the ACCME that actually was the first trial to show that for patients with 1 to 2 positive sentinel lymph nodes, you don't necessarily benefit from completion axillary dissection. So it's a similar design. The patients that entered the trial were a little bit higher risk because in the group that had the axillary dissection, about 44% of the patients had residual non-sentinel nodes, which is more than we saw with the ACCME was about 27%. So even with a higher disease burden, there was no significant difference with the completion axillary dissection. So again, another piece of the puzzle that actually makes us more comfortable avoiding axillary dissections for patients up front with upfront surgery if they have 1 or 2 positive nodes, even you can probably stretch it to 3 sometimes. So that was a nice trial, well done, similar size almost to the ACCME trial. And now we have at least 4 trials that actually show essentially the same thing. There are other trials, including the one that was also presented, the INSEMA trial, that actually is trying to avoid sentinel lymph node biopsy altogether versus sentinel lymph node biopsy, because some low-risk patients probably don't need sentinel lymph node biopsy at all. And they present some quality of life data, which showed a little bit of detriment in quality of life, particularly in the arm. But that trial also randomized patients that went on sentinel lymph node biopsy to then, if they had 1 to 3 positive nodes, I believe, then to completion axillary dissection or not. So we'll have even more data on the question of do you need an axillary dissection, but we also will have hopefully good data from that and other trials that maybe in low risk patients, you don't even need sentinel lymph node biopsy because the majority of the time it's negative anyways.
So who do you, so that's great. And I was really impressed with the INSEMA trial and the suggestion that, we've seen this before in other data, a sentinel node, we all feel much better. It's way better than doing a full dissection and certainly better than dissection and radiation but it does have some morbidity, even though it doesn't appear from those data and others to affect overall quality of life. You can have arm morbidity, of course, and it can go out far. So who do you actually select, especially based on, seeing more and more, it's okay to not dissect some people and that it does have that impact. Who do you select out to not have a dissection at all or not have even a sentinel node these days?
Yeah, so I mean, obviously the trial is a little ambitious because it includes patients with T1 and T2, even under or equal to 5 centimeters. That's pretty large size in my.
That's bold. That's very bold.
Yeah, it's a little bold. So I would say though, for
Spanish study, right? Was it? Where was it? It's ABPSG, GBG, and
yeah, it's European study. But I think for T1 patients, with moderate to low grade disease, I think it's reasonable to consider that as part of the trial, of course, until we prove that's what we need to do. Most of the times we can make these decisions in terms of how we treat them systemically without the knowledge of the nodes. And for example, ER positive, HER2 negative patients would typically go to genomic profiling test, and if they're low risk, they will either get endocrine therapy or chemoendocrine therapy. It's very unlikely that the patient that we will avoid in such patient, if we'll avoid a sentinel biopsy, the patient has 4 or more nodes. And it appears that the use of radiation to the breast has some effect in the axilla, although they don't intentionally treat the axilla for whatever reason, and we saw that in other trials as well. So yeah, I think for these low risk patients, obviously patients that have DCIS, microinvasive disease will fall into that category as well, if they're not extensive. So I think there is a role, and hopefully these trials will show that it's safe to do so. So far, it's interesting, but the escalation of surgery has never shown any detriment. Starting from the BO4 trial, we didn't see a survival benefit, but we didn't even treat the nodes in these patients. So we'll see. But I think it's hopeful that we'll minimize the morbidity further.
So again, Laura, do you have thing? Oh,
yeah,
Matt,
but let Matt jump in first.
No, I was just going to, one point that I was thinking about, and that is, when I first started my training and early in my career, one of the things that we did was we would make decisions about giving chemotherapy based on nodal status, right? Gee, this patient is node positive, you should give chemotherapy. And so we really moved away from that. Obviously, thankfully, we use information about biology, but there's been a recent wrinkle in all this, and that was, of course, the recent FDA approval of abemaciclib, which to get into that trial, you had to have 4 or more positive lymph nodes, or if you had 1 to 3 positive lymph nodes, you had to have other high-grade features, either a 5-centimeter tumor or high-grade disease, or of course a high Ki-67. So it begs the question, of course, and that is, you see a patient in your tumor boards, and you've done a sentinel lymph node biopsy, and the patient has 2 out of 3 lymph nodes, and the oncologist is asking for a lymph node dissection because it may or may not affect whether or not they give abemaciclib. So I think we're still trying to sort all that through. It is a bit of, again, as I said, it's a bit of a wrinkle. I think most of the time, as Terry said, you can really figure this out just based on the initial biology. So most ER-positive tumors that are low grade are not going to have a big axillary burden, and you're probably not going to miss that. But there may be some questions occasionally about this issue about, do I look for more lymph nodes because it's going to affect how I treat the patients, with or with not let's say a drug like abemaciclib.
Thank you. Laura, did you have anything else to add to that?
I think just briefly, I think with one of the criticisms, of course, is the 11 is the complexity of the subsequent analysis of the radiation that was delivered. And I think for those of us who are breast radiation oncologists, we're thrilled to see de-escalation of axillary surgery, but then it actually muddies the water for us in terms of what we do. And so the Synadar data, they say that 70% of their, or 77%, of their patients, they have the radiation records. And I think it will be really nice to know how were these patients actually treated. And I think the challenges was the 11, 15% got a third field, which they weren't supposed to get. And so are we intentionally making up for less axillary surgery with more radiation? And if that's the case, that's helpful to know. And then I think in the INSIMA trial, they actually in 2020 published their radiation data, and they looked at how much of the nodal basins were getting treated. So 50% were getting prescription dose to level 1, 25% were getting prescription dose to level 2. So I think in that trial, all of those patients were going on to get adjuvant radiation. So just something to remember that as we're de-escalating local therapy with regard to axillary surgery, we may be taking, for example, partial breast off the table, or maybe we should, or maybe we shouldn't, but we may not know. And so that's where I start to wonder if we know that we're adding radiation inadvertently or not to the axilla with breast, sort of whole breast tangents, where does partial breast fit into all of this as well? So I think those are some of the questions that I look forward to the full manuscript for both of these trials.
Yeah, you bring up a really good point, Laura. As we and many of the people on this panel plan national trials, and there's this tension to being proscriptive, and you must do it the way we say to do it, otherwise you can't put the person on trial, versus letting doctors be doctors around all the other ancillary stuff to just address the one finite, focused question, but sometimes it leaves us with murky side information.
I mean, one other point I'll very quickly make also is that we also have the data from the Amedco trial, the AutoSAR trial, where they replace essentially axillary dissection with axillary radiation purposefully, and the axillary radiation arm had equal local control, but also had less lymphedema. So whether intentionally or unintentionally we get to the axilla and radiate, I think not taking the nodes still is better than taking the nodes out. And I think that's what we'll learn. So depending on your degree of comfort, you can just treat as C11 or maybe treat as Amedco. So either way, I think you do get benefit in terms of reduction of lymphedema.
Completely agree. I would love to not have to treat all of these patients as per Amedco. I don't think they all need superclad radiation. I don't think they all need internal mammary radiation. And I think the question is, how do we do that in a data-driven fashion rather than that just sort of gut feeling that they fit in the Z11 bucket versus the Amedco bucket?
Good. All right. So let's stick with early stage disease. And Matt, I'm going to pick up on something you said a few minutes ago, where you said, with these node positives, we don't necessarily need chemotherapy. And yet we had the RxPonder data update. Remember, the theme of the meeting seemed to be updates. And for the RxPonder study, which as many of you will recall, that's the randomization to chemo or no chemo in patients with hormone receptor positive, HER2 negative breast cancer with recurrence scores of 0 to 25. And Matt, do you want to comment on the results of that, and then specifically why I'm targeting your comment about node positivity in the premenopausal group?
Yeah, absolutely. So as you said, this was an updated analysis. Many of us have seen the paper that was just published in the New England Journal of Medicine, I think just a few days or right around the time of the San Antonio meeting. So what this was an updated analysis. So just to remember, the prior analysis, there was a median follow-up of 5.3 years with 481 invasive disease-free events. And so with this particular analysis, there was longer follow-up, not a whole heck of a longer follow-up, but indeed went from 5.3 up to 6.1 years in the intent to treat population. And that did translate into substantially more events. We went from 481 up to 553. So I think, one of the things, of course, when RxPonder came out, there's always those people that, probably are maybe the naysayers would say, well, are you sure that you can really omit chemotherapy for these node positive patients? And I think what we saw with this update analysis, indeed, for the postmenopausal group of patients, really no change at all. I'm looking at the data right now. It's in front of me, the 5-year IDFS of 91.2% for the chemoendocrine therapy arm and 91.9% for the endocrine therapy arm. Same really type of data for distant relapse-free survival. The corollary, or the other group, of course, is the sort of the head scratcher, which is the premenopausal group, where there clearly was reported in the New England Journal of Medicine paper an improvement in both an invasive disease-free survival as well as distant disease-free survival. And I think as we saw this, the updated data here, I don't think we saw anything different in terms of the premenopausal group per se, but just indeed that that benefit was maintained. The second thing with regard to this analysis was Dr. Klinsky and the statistical group at SWOG did some post-hoc analyses. And these analyses were, again, not necessarily planned, but they were attempting to look at the issue of, first of all, for example, they looked at the issue of N1 MIC versus N1. And as you might expect, the number of events in the N1 MIC group and the overall number was small, but there still seemed to be some benefit in this premenopausal group, albeit, relatively small numbers. And then the other question that they looked at was this issue of ovarian function suppression. We know, of course, from this particular trial that the majority of patients did not receive ovarian function suppression. It's actually the minority of patients. And so what the investigators tried to do is to really look at this small group of patients that did receive ovarian function suppression. And they did a landmark 2-year IDFS study. And when they looked at that, the bottom line is it didn't appear that it really changed the overall conclusions of the results in the premenopausal group, and that is that there seemed to be benefit regardless of whether there was ovarian function suppression or not. The bottom line is it's such a small group of patients that I don't think one can really make a lot out of that. Again, I applaud the investigators for trying to look at this because so many people asked about it. But at the end of the day, I think we're still left with this question, which is, gee, if we had given proper endocrine therapy for the premenopausal group of patients, would they really benefited from chemotherapy? Now, obviously, that's still a very important question to answer.
Yeah, I think, and I think their analysis looking at the ovarian function suppression, they cleverly also tried to look at amenorrhea. And we know from other studies like NSABP, the Sandy Swain trial, what's that, B32?
It was B30, but it was a conglomerate of other drugs. But B30 was the main one.
Sorry, thank you. We know that amenorrhea impacts on outcomes, and they showed that regardless of treatment arm, people who had amenorrhea or got ovarian suppression in either arm had better outcomes. They didn't do a direct comparison, which is interesting, and I think I understand why they didn't. That would be like apples and oranges. But I will say, then, what are we to do with this, and how do we reconcile? And somebody put in one of the questions of one of the viewers, our responder has made it difficult to risk stratify for premenopausal women with node negative, they think, as well. And what are we using for our recurrence scores for that? So, are you still using recurrence score in premenopausal women, period? Are you using it only in node negative now, or do you still use it in some node positives? And that's my bias, but Matt, do you want to comment on that?
Well, I think, the secondary analysis of TAILOR-RX, we ran into the same issue, right? And that is that there seemed to potentially be a subgroup of patients who were premenopausal that were node negative that seemed to benefit, and people were trying to find the right cutoff. And I think in reality is, I'm not sure we actually know what that cutoff really is. My take on this, and this is what I tell patients when I see them in the clinic, and that is that, if I get an Oncotype DX recurrence score, it's going to give me prognostic information. And so we have that information that can be helpful, quite honestly, for our patients. So having prognostic information can be quite helpful. And if you're postmenopausal, it gives you to be predictive in the sense that we know that chemotherapy does not benefit you. I think what we have to have is that careful discussion with our patients, and that is that we know that the trials such as SOPT and TEXT have shown us large benefits of utilizing proper endocrine therapy, ovarian function suppression, and then of course aromatase inhibitors, which just obviously we're not given in this trial to any great degree. And so we're in a data-free zone, and so there's two ways to approach this, of course, and that is to say every woman who's premenopausal and node positive should get chemotherapy. I don't think we're ready for that, and I think the NCCN has really come down on the sense that there are probably two approaches here. One approach is to utilize chemotherapy, but also another approach is to say, listen, if we're going to give proper endocrine therapy in this situation, the benefit of chemotherapy is really unknown. It still may be there. We don't know for sure. But obviously this is still a major point, and I think it's going to lead to hopefully a clinical trial that, and Terry can comment on this as well, that will hopefully answer this question once and for all.
Yeah, I know Energy is working on that, right? Something to address this.
Yeah, and we hope that, we're still under review and everything, but, we hope that trial will become a reality. And if so, the design is to give ovarian function suppression and endocrine therapy to both groups, and then randomize one group to chemotherapy versus not.
We didn't know that was going to be the best treatment when Responder was designed, right? It was pre knowing the results of SOPT and TEXT. Diane, do you want to comment on this? We're going to design a trial that's going to randomize women to chemo or no chemo, and they all get ovarian suppression and an AI or tamoxifen depending. As a patient advocate, how does that sit with you?
Well, I mean, I meet both types of women, right? Who, the thing is, if you're randomizing them, that's one thing. There are some women who want to play it conservative and, who want everything we can give them. Maybe do a component in that trial where you give them the choice.
That's a
The
good.
NCI doesn't like to pay for that, so.
Well,
but also introduces bias. Unfortunately, that's the issue.
Yes, but like we're doing a trial where a lot of women will be randomized, but then we give the option of those who feel strongly one way or the other to be able to pick. At least then you've got the observational arm. But just an idea. But there's both types of women out there, so it'll probably accrue if it's promoted correctly.
Well, we didn't think Taylor X or responder would necessarily accrue, and they did beautifully. So I think you're right. And if you have true equipoise, we should be okay. Someone did ask if the viewers, are there cases where you wouldn't give chemotherapy and would just give optimal endocrine therapy to a patient with N1 disease and premenopausal? And I think the overwhelming answer is, of course, absolutely. Right, Matt?
Yeah, absolutely. And I think just having that careful discussion with the patient and to say, this is what we know. And, you know, when our responder was designed, and as you said, we didn't know what we know today. And in the reality is one gets large benefits of giving proper endocrine therapy. And the real question is, when you do that, is there even additional benefit of chemotherapy? There may be, we don't know. And of course, that's the question that we're going to have to answer.
But interestingly, as you know, and there was a debate also about that, whether the benefit in responder and Taylor-X is ovarian function suppression or some or not. And actually, after the debate, they posed a couple of questions, right? And when on the low risk node positive patient, I think it was almost about 50-50 people that would give chemotherapy or not. In the more higher risk patient, it was a little bit more chemo, but still a good proportion of patients actually thought that the benefit maybe is from ovarian function suppression, didn't pick that. So I think it's time to do this trial and then actually get an answer.
Yeah, I hope we can do it.
Whatever that is. Right.
Yeah, no, it's a really important question for these young women. There's been a question also that asked, so before we get to the question, because it flows nicely. So let's pretend we need to give the chemotherapy. Say N1, hormone sensitive, young or old woman, but you still need to give her chemotherapy. Let's pretend she's a middle age, about my age, in the 50s. And is that middle still, I hope? And
Well, that's young.
Thank you.
That is
Welcome.
Thank you. And we had another big data analysis, meta-analysis from the Oxford group that compared anthracycline-based regimens to non-anthracycline-based regimens with taxane. It was a funny study, but who wants to take a crack at that? Of which chemo should we be choosing on Monday morning for our patients? The results suggested that the use of anthracycline won overall, but it was kind of strange because when they looked at a subset or stratified by whether the anthracycline was given concurrently versus sequentially with the taxane, if they got it concurrently, which the regimen typically I think of as TAC, versus sequentially, it seemed to add benefit concurrently, but not sequentially. And clearly, there was no dose-dense ACT in that, which at least in North America is one of the faves. Who wants to start with untangling that? Matt, since you and I are the only ones who actually administer this stuff on this call.
Yeah, I think all of us were, a little bit confused by that. I don't know if confused, but, part of it relates to, the types of trials that come in, and, we obviously are delivering our treatment differently than we did before. By the way, the Oxford overview has nicely shown us that giving dose density or giving chemotherapy dose dense makes a difference. And so that was a major advance. Certainly this whole issue of, concurrent versus sequentially, I think it's pretty clear that we're not going to go back and give TAC. I'm not going to, subject my patients to that. And I won't have that discussion with them. I do think that, if I think about, some of the data that has been most helpful to me as I think about over the last, 10 years in this space, and that is the fact that, with the issue of anthracyclines, it seems to us that really we probably don't need anthracyclines for these lower risk ER positive tumors with, that are node negative or, maybe 1 to 3 positive lymph nodes from the ABC analysis. Whereas we clearly see benefit of the anthracyclines when you go into, of course, the triple negative space, as well as in that very high risk ER positive, let's say high grade multiple positive lymph nodes. So I'm not sure what to take from that particular meta-analysis, other than to say that some of this is maybe is historical, and I'm not sure it's going to change what I do on Monday morning. Is the bottom line.
I'm with you, Matt, as usual. Anybody else want to add anything there?
No, there was no patient level data available on quality of life, but just anecdotally, I would say patients are happy to get rid of anthracycline. So
we agree, and we'd love to be able to do that. I think, but for the higher risk patients, we don't want to throw the baby out with the bathwater. That's part of the concern here. But we totally agree, and we keep working towards that. We promise, Diane.
Yeah.
So it's not. So let's pretend you get your chemo, you get your ovarian suppression because you're a young woman who had high risk. Nobody checked an oncotype because you had multiple nodes positive pre-op, and now you're on your ovarian suppression and your AI, and you are suffering from arthralgias. One of the people who's listening said, any drugs such as Cymbalta or Lyrica showing any evidence for improvement in arthralgias in these patients? Matt, this is. You give duloxetine or for
I haven't given a lot with those, certainly with those particular medications. I think there's some, a bit of data. I think where we've seen, at least for the arthralgias, the very nice data was with acupuncture, showing benefit there. And what do you do?
Yeah, I typically, I use, thank you. I use a fair bit of good old fashioned stretching, exercise, ibuprofen or naproxen, and Tylenol, and then acupuncture if people can access it. It's not so easy. It can be expensive for people. But the data from SWAB were really quite impressive for 12 weeks of acupuncture. And then, after stopping, even 12 weeks after that, there was a near halving of the, biggest pain. I forget what the score they use. Their pain index at 24 weeks. It was at 12 weeks and then it was sustained even when they stopped. So I definitely try and get people to acupuncture. Often this one for me is like, it's the 60s. If it feels good, do it, because I want to support them and have them, so sometimes it's Pilates, sometimes it's heating pads, it's whatever, patients will take and helps to support them through it. Do others have things they've suggested for patients suffering with that? And I think we know also that, 20% of people are going to come off. And so just being there and saying, if it's intolerable, let's try the tamoxifen. If it's, that's, I think, having that conversation and not having people kind of suffer indefinitely if it's really, something that's impacting their life in a really horrific way. Is something I try and address with patients. All right, another question. So you get to 5 years, and the question is, how do you decide about extended endocrine therapy for your patient? Do you use any of these newfangled tests, for example, the breast cancer index? How do you decide other than just, their risk originally? Anyone want to start with that? Terry, why don't you start with that? Because you know all this stuff.
So,
This last big meeting.
So the breast cancer index, as you know, is a test that actually has two components. Has the ratio of H over I or homeobox 1317B interleukin B receptor ratio, which predicts endocrine sensitivity, and then the molecular grade index essentially for prognosis, and has been assessed in extended adjuvant endocrine therapy trials, and both in the MA17 trial and then the Transatom trial and the IDEAL trial. So there was 3 trials: tamoxifen to tamoxifen, tamoxifen to an AI, and also AI, tamoxifen followed by AI, followed by AI. And in all 3 trials showed an interaction in terms of high H over I patients have more benefit from extended endocrine therapy, low H over I patients did not. We did look at that in the NSABP B42, which is a trial of 10 versus 5 years of AI. The first 5 years could be AI or tamoxifen followed by an AI. And we didn't find a significant difference up front with the results, obviously, because the sample size in these trials is usually lower than the original trial, so the power is less. But then, because there was an observation that distant recurrence in B42, the difference started to accumulate after 4 years. There was a non-proportionality in the hazards. So we ended up looking at the conditional analysis, looking at the age of array according to first 4 years or year 4 to 10, essentially. And what we saw there was that the benefit from extended endocrine therapy was realized not in the first 4 years, but obviously in the second part from years 4 to years 10. And it was more significant. It was significant in patients with a high H over I ratio, and particularly for not positive patients. So with that sort of type of analysis, you can start getting into what are the patients that potentially can benefit from that. And usually it's the high risk patients, not positive patients or high risk, not negative patients that you consider the test to give you an idea of whether you should continue or stop. But it may also have some value in the moderate risk patients, because that's actually the patients that you are somewhat on an equipoise whether you should continue or not. A very high risk patient, say with multiple positive nodes, you probably will continue. So that's kind of some of the thought process of that. And again, not every study we do will always be concordant to other studies. Sometimes we'll see an aberration to one, and the B42 was a little bit of an aberration, although to some extent was consistent with what they have seen in other trials.
And Matt, are you doing these tests, or are you doing it more based on their clinical presentation and tolerance?
Yeah, so I think in general, the first thing we start out with is your clinical risk and your clinical presentation, because I think that's going to be the major driver, especially in a patient, let's say, that's tolerating the drug well and doing well, but remains at high risk. And so that's how we would manage. But we commonly do come across these patients, as Terry said, where there's equipoise. Maybe they're having some side effects, they're not quite sure. The data from B42 really reminds me in some ways of some of the issues that we have with the individual trials with tamoxifen, right? You have some trials that are positive and some that are negative, but the reality is when you put all the data together and you do a meta-analysis, everybody gives the drug tamoxifen based on that. And so, I think we had this sort of consistent data that was generated, as Terry said, from ADAM, from IDEAL, from MA17R, and all of a sudden we see B24. And so the question is the B24 data, is it truly an outlier? And I think, as Terry said, it's no matter the way you slice it, it's the results as they were pre-planned are negative. But when you look at the data based on the fact that the curves really began to diverge, at least in terms of events, after a couple of years, there may be something there. And my point is, I think we're probably due for some type of a meta-analysis to put all these data together and ask the question of, what do we see? And of course, there will always be some trials that are outliers, but thus far the data have been fairly consistent. I didn't answer your question, and that the answer is that, do we do it routinely? And the answer is no, we don't do it routinely, but we do it in those situations where there is some equipoise, and sometimes it can be very helpful for patients in that scenario.
Thank you. Before we shift into advanced disease, where there were some interesting abstracts, Laura, one of our viewers has asked about, and this is relevant to the kind of trying to do less versus more and the debate, how is partial breast radiation different from intra-op radiation? Just want to give a quick response to that.
Yeah, just it's really just the volume that's covered. Partial breast tends to be the cavity with a relatively generous margin, and then many of the intraoperative techniques are really just covering the surgical cavity with a couple millimeter margin. So it's really just a different treatment volume and then a different dose fractionation. So a couple ways.
Thank you.
That answered their question, but hopefully it did.
It answered my question, because I was like, I don't know exactly. I know kind of, like one's in the operating room and one's in the office. Right, Diane? Were we answered?
Yep. I had intraoperative, just to mention, and my cancer came back. Yep.
So you definitely needed radiation. It came back in the breast?
Pretty quickly. Yeah, right in the same area. Yep.
All right. That's why I'm sorry for that. And I'm glad you had effective, good local therapy after that.
Oh, yeah.
Good. Not that that's not effective, good local therapy. It just wasn't effective enough for you. It
Right,
failed you.
and systemic after that.
Yeah.
That was the only time I had radiation and that happened, so
You bring up an important point, which is, that's why we have to study this in big studies to see differences, because sometimes even with effective things that work for many people, they don't work for all,
right.
even when they're an advance.
We have to slice and dice the data. Every woman is different. And I love what's happening in oncology right now, where we're just getting finer and finer subtyping.
Thank you. All right, so let's switch gears and go to advanced disease. And some of the most exciting data, I think, just in terms of, it's the first time we've seen real efficacy data from an oral serum estrogen receptor degrader. The Emerald trial was presented. Matt, as my medical oncology colleague, do you want to comment on the results of Emerald, which was a phase 3 of I can't even say this, Elacestrant. Is that right? Elacestrant, or an oral SERD after progression on prior endocrine and CDK4/6 inhibitor. So second line therapy for hormone receptor positive metastatic disease.
Sure. So just as a background, we know for targeting the estrogen receptor that there are 3 ways to do this right now. One of them, of course, is to utilize a SERM approach, and we even have some SERMs that are still being studied, including lasofoxifene, endoxifen, basodoxifene. And then we have, of course, aromatase inhibitors, which have been a real advance. Ovarian function suppression, so we're getting rid of estrogen. And then we have what I think is really one of the most promising approaches, which is to utilize an approach to degrade the estrogen receptor. And we've known for a while that fulvestrant, it really does give you a superior outcome, at least in the metastatic setting, compared to aromatase inhibitors. We have data from the Falcon trial. Now, some would argue that that's incremental, but there was some benefit there. And so the major barrier, of course, has been to be able to create a drug that's oral, because not all patients would and should and want to get an injection, either on a monthly basis for a long period of time. So there are a number of these drugs that are being developed by companies. This is really the first shot across the bow. This is an oral selective estrogen receptor degrader. And in this particular trial, patients were randomized who had a history of ER-positive metastatic breast cancer, who had progressed after 1 or 2 lines of endocrine therapy. And one of those lines had to be a CDK4/6 inhibitor. And so the randomization in this case was to either investigator's choice. And of course, that could have been fulvestrant, anastrozole, letrozole, or exemestane, or the investigational arm was elacestrant. And elacestrant, just again for people, it's a drug that's given once daily. So for this particular trial, there was co-primary endpoints: progression-free survival overall, and then in the ESR1 mutant, which again is one of these groups of patients that we, of course, have really seen as an important prognostic group that occurs in the setting of aromatase inhibitors. That is, the longer you're on the aromatase inhibitor, we see that this particular group of patients, this type of mechanism emerges. And so the investigators had a predefined co-primary endpoint looking at this group of patients. So I'll cut to the chase. This was a positive study. And this was a study that was positive in the sense that it was statistically significant, but some would argue perhaps not clinically significant. So the progression-free survival in the standard of care arm was 1.9 months. Now that was shocking to some people. Perhaps it wasn't as shocking to others, but those are the data. Elacestrant median PFS was 2.79 months. So that was an increase of 1 month in progression-free survival. Again, statistically significant, but perhaps not clinically significant. However, I would argue that the data in the ESR1 mutants were somewhat more promising. So there we saw an improvement with standard of care, that is fulvestrant, from about 1.9 months up to nearly 4 months. So what that suggests to me is that much of the benefit in this with this drug is actually being driven in these ESR1 mutant tumors. And so, I think, and Anne, you know this, we presented data a couple of years ago at the San Antonio meeting. And I think this is the first time I saw it. It was from our trial in the metastatic setting comparing endoxifen to tamoxifen. And we had two groups there. We had the patients that progressed on CDK4/6 inhibitors, and we had the group that did not. And that was the first time I saw with my eyes. I saw that the median PFS in the group that progressed on CDK4/6 inhibitors was 1.8 months. And I was shocked by that. But I think what we're seeing now is that indeed, in a large trial of over 400 patients, that indeed is the case. And of course, we saw the data from Veronica at ASCO, same exact thing. So it looks like once you progress on a CDK4/6 inhibitor, there really isn't much endocrine sensitivity that's remaining. And obviously that means that we have a lot of work to do as a research field. So that's my take on the Emerald data.
All right, thank you, Matt. And did you want to comment, Diane?
Only that I'm really glad that there are 10 other SERDs in development right now, because the adverse events of this wasn't good either. Nausea was pretty strong, and fatigue and vomiting, and I mean, it's one thing if it's oral, it's convenient, it's easy, but I mean, we have to look at the side effects.
Yeah.
So maybe I can comment on that. Nausea certainly was a bit higher. If we look at the fulvestrant, it was about all grades. It was about 16%. In the patients that received the drug elacestrant, all grades, it was 35%. So it certainly was a bit higher with regard to nausea. And we've seen that, by the way, as a general, I think as a class effect with these oral SERDs. We've seen a bit more GI side effects. We've seen some other side effects, cardiac side effects, other side effects. And we'll have to look as we look across, you're exactly right, as we look across these other SERDs to see, as we move them into the earlier spaces where there's truly endocrine sensitivity, because this is not an endocrine sensitive space right now.
Right.
If we move it into that endocrine sensitive space and we see benefit, what's that risk benefit ratio?
Right.
All right. Well, and Diane, as usual, you make a terrific point. We need to be able to tolerate these drugs. So the Emerald trial also had a pretty neat analysis where they looked at whether or not patients developed ESR mutations. And if they had ESR mutations on trial, they seemed to get a much greater benefit proportionally. There seemed to be an interaction between the randomization arm, and they got greater benefit from being on the oral SERD compared to the other endocrine agent, or the fulvestrant. There was another abstract that was also presented, the PATA-1 trial, where patients were randomized to be treated with an AI and palbociclib, and be followed with an endocrine, followed by ctDNA to look for an ESR mutation. And if they were followed and had the ESR mutation, then they were switched to fulvestrant, versus the group that didn't get switched and was just followed. And they also showed, even though only about, I think 50 or 60% were able to ultimately get fulvestrant on the arm that didn't switch with an ESR mutation, and this was with palbociclib, they showed a disease-free survival advantage to this monitoring. I don't know if you want to comment on this, Matt, and if you're getting ESR or ctDNA for ESR mutations on all of your patients starting this past Monday.
Well, it's a great question. And I think if there's one takeaway that also came out of this this meeting, and that is, I think we are going to be using these circulating biomarkers more and more. Obviously, to use them, they have to have clinical utility. So it's not enough just to say, here's the result. Oh my gosh, it's going up. Now what do I do? Because that's the worst thing for my patients, because it creates anxiety, and it also creates confusion, and sometimes can make the clinician even more confused. But what this group was trying to do is to really ask the question is, does a rising ESR1 mutational burden, or if you will, ctDNA, circulating tumor DNA that expresses this mutation is present, excuse me, does that mean something in terms of clinical utility? Should we do something different? And as a background, this is not uncommon. We see this anywhere from 30 to 40% of our patients who are treated with aromatase inhibitors. Number two, it still occurs in the presence of palbociclib. So when you treat a patient with an aromatase inhibitor and you compare, let's say, the data that's been generated, AI versus AI plus palbociclib, it doesn't appear that the palbociclib is preventing this mechanism per se. And so with that in mind, these investigators were really asking this question of, okay, you're on palbociclib and you're on an AI, this mutation is emerging, you don't have clinical evidence of progression, should we do something different? And I have the data open and just in front of me, so I can make sure I'm saying it, but there was 1,000 patients that who were treated with an AI plus palbociclib, and about 279 had a rising ESR1 mutational load that was seen. And these patients, of 60 of those, of that 279, actually did indeed have a synchronous progression-free event, or excuse me, a progression event. So, that rising ESR1 mutation in 60 of those 279 was associated indeed with true progression, but the other groups did not. And so they randomized 172 of these patients who had a rising mutational burden. It had no event, so their scans showed that everything looked okay. And they were randomized to either continue on with the AI plus palbociclib or to switch to fulvestrant while staying on the palbociclib. And the bottom line is that there's two things I think that came out of this. Number one is that if you have a rising ESR1 mutation, it looks like that this is portraying overall that there's a group of patients that are going to have a higher risk of event, because in that control arm, the median PFS was only about 5.7 months. For those patients who were switched to fulvestrant, there was what I would appear to say is not just a statistically significant, but a clinically significant improvement up to 11.9 months. And so that the hazard ratio there was 0.63. It was the stratified hazard ratio of 0.61, highly statistically significant. So I think what this is telling us is that two things. Number one is these ESR1 mutations, we know they're real. We know that they occur in the presence of AI. We know they occur in the presence of AI plus CDK4/6 inhibitors. And that it appears that using a SERD is probably a superior way to approach these patients who have the rising ESR1 mutations. However, what we didn't know, we don't know for sure, of course, and the authors attempted to address this, and that is, well, if you would have just switched them at the time they had progression, that is from at the time that they truly had progression of disease on the AI plus palbociclib arm, would there really be much difference? And this was a crossover cohort, and the bottom line is in the second line setting, there was about a 3.5-month benefit of fulvestrant plus palbociclib, and not all patients crossed over. So I think what my take home from this is twofold. Number one is I think fulvestrant and the SERDs are going to be better drugs overall. I think number two, we're going to be paying close attention to these ESR1 mutations. Number three, there's another trial that's going to be looking at the same thing. It's the Serena 6 trial, which is utilizing AstraZeneca's SERD. And it's really going to be the same design, same idea, randomizing patients who have a rising ESR1 mutational load to either continue on that same therapy versus switching, in this case, to an oral SERD. So are we ready to do this today in the clinic? And I think the data that I wanted to see, Anne, was the data with regard to PROs. If you're progressing early and there is symptomatic deterioration because of the burden of disease, that would suggest to me that we probably should be switching these patients earlier. We still don't have that data. Obviously, we don't have overall survival data, so we'll look forward to that.
I think you make a critical point, Matt. So far, the data for checking the ESR mutations or any circulating tumor finding to date, it's very prognostic. It's somewhat predictive, but not so clear that we have helped people yet in terms of any meaningful outcome to patients, although I'm very optimistic and think we're going to be doing more and more of this, certainly in our research, but not something I'm sending in my clinic yet outside of a research context, because we haven't necessarily improved outcomes in terms of, again, outcomes that matter to patients, like does switching earlier make you feel better or live longer or spare you chemotherapy? I don't think we know the answer to that yet. Any other comments around that? Okay, so we are actually at time. I will say the one area we didn't get to, but we did allude to when we talked about the CDK4/6 inhibitors, was the pretty striking data from the Monaleesa analysis, that they clearly now, for Monaleesa, what is it, 2, 3, and 7, they all have an overall survival advantage. Very exciting. And, you know, subtypes, it matters what PAM50 subtype you have, but that's also not something we're checking in prime time in clinic, but hopefully in research, we'll figure out whether we should be someday. And there was a novel CDK7 inhibitor that was presented as well, but again, not ready for Monday morning, though exciting, and I think we all want to stay tuned. Does everybody want to add any other big take homes that you want to add, Terry, from San Antonio? Biggest change, biggest thought that you brought home? Even though I don't know if you were physically there, so yeah, you brought it home.
Yeah, it was not a lot. I mean, unfortunately, I mean, we kind of like continuing the path that we have mapped out. I mean, I think the Synadar was confirmatory, and it was good to validate that we don't have to necessarily do axillary dissections for these patients. The lymphedema data from Memorial Sloan Kettering were interesting because they showed that Black women and Hispanic women have actually higher rates, particularly Black women. And whether that's a confounding of stage of disease or BMI and other factors, it's uncertain, although they're statistically you know, corrected for that. But sometimes you may not be able to control all variables. But lymphedema is becoming a major issue that we pay attention today.
I would like to just add that I'd like to see more women referred to specialists in that area. There are so many wrong ideas going around about lymphedema that are left over from the old days that I think people need to know how to manage this. And there are options available today that weren't available when I was first diagnosed. So I highly agree with you.
Very good point. And we do also explore now some surgical options, as was discussed in the educational session, with lymphovenous bypass and even lymph node transfers. But lymphovenous bypass is kind of catching on. We also need more data. But even for the patients that we do have to do an axillary dissection, that will receive radiotherapy, we have ways now surgically to potentially reduce the risk of lymphedema. So that was another important piece of evidence. But I agree with you. I think the myths of the past, such as, for example, no vena punctures, no blood pressure cuffs, no flying, you know, with lymphedema, are all gone. Mostly it's now prevent infections of the arm, because those increase risk of lymphedema, and BMI is obviously a major issue. So in our place, every patient that has axillary surgery, whether it's a sentinel lymph biopsy or axillary dissection, it gets a consult with lymphedema clinic, and we have likely many lymphedema specialists that actually care for these patients and educate.
Probably once again an access thing or information about why that weight-bearing exercise is actually good for lymphedema,
Yes.
and preventative, and that's probably what's going on, is my guess. Laura, any final thoughts from your end?
Just to piggyback on that conversation, I think the data from Memorial Sloan Kettering confirmed that we can still see lymphedema incidence rising out to 2 years in the patient population who got, almost everyone got radiotherapy. So I would say, in terms of patient education, they want to be out of the woods with that lymphedema risk as you're seeing them. But I think a reminder that we still need to keep a watchful eye for multiple years out past their local therapy.
Yeah, it's striking when it happens, but it does. Matt, comments on?
No additional comments. It's been a great session, and as always, you do a fantastic job moderating.
Thank you. Diane, final word?
No, I'm just really excited because for, about 15 years, I think ER positive was just kind of the pushed aside a little bit when we knew we had to do so much for HER2 patients and for triple negative. And now it's wonderful to see all this activity in ER positive.
Completely agree, and great ending comments. I want to thank all of you. All of you are terrific. You gave great answers. I hope everybody knows exactly what to do in their clinics now. I want to also thank the sponsors of this session, Biotheranostics and Pfizer, and I hope you all have a great evening. Take care.
Thank you.
Bye-bye.
Bye-bye.